Hey guys, so this is going to be chapter 51. This is the concepts of care for patients with conditions of the biliary system and pancreas. So the biliary system is made up of the liver, gallbladder, and pancreas, and the biliary system secretes enzymes that promote digestion, and when this is impaired, patients can have inadequate nutrition. So whenever you think about those gallbladder problems, and I know some of us have even had our gallbladder taken out, um, what has caused this disease is actually cholecystitis, okay? And that's going to be an inflammation of the gallbladder. Now, cholecystitis can be acute or chronic. For our acute types, we have calculus and acalculus. Remember, A means without. So calculus is the most common, and it's caused by gallstones or calculi. Whenever you have these gallstones, it is called cholelithiasis. These gallstones are going to obstruct your biliary ducts. Trapped bile is then reabsorbed, and it's going to irritate the gallbladder wall because it can't pass through those ducts. Reabsorbed bile, impaired circulation, edema, and gallbladder distension can lead to necrosis and gangrene in the gallbladder, which may eventually perforate, and that can cause, that means to rupture. It can cause that perforation, and it can result in an abscess or peritonitis. Acalculus, that means without, so without gallstones. Acalculus cholecystitis is inflammation without gallstones present. It is related to biliary stasis, which is caused by conditions that affect regular filling and emptying of the gallbladder. For example, if you have twisting or kinking of the gallbladder neck or cystic duct, that can cause reflux of the pancreatic enzyme and sphincter of Oddi dysfunction. This is most commonly going to occur in patients with sepsis, severe trauma or burns, long-term TPN, multiple organ dysfunction syndrome, major abdominal surgery, and hypovolemia. The 4 F's are going to be those who are most at risk for acute cholecystitis and gallstones, and the 4 F's are female, 40, fat, and fertile. So larger ladies who are over 40 and haven't hit menopause, they are going to be at higher risk for acute cholecystitis. Now moving on from acute, we have chronic cholecystitis. This is when we have repeated obstructions. The gallbladder becomes fibrotic and atrophied, and this is going to cause decreased motility and absorption. Pancreatitis and cholangitis can develop due to the backing up of bile into the rest of the biliary system. Signs and symptoms are going to be jaundice, which is the yellow skin, and yellow sclera. Causes of cholecystitis can be genetic, but they're likely related to familial nutrition habits such as excessive cholesterol and a sedentary lifestyle. For our signs and symptoms, these are located in box 51.1, but some of these include right upper quadrant pain, because think about where your liver and your biliary system really are and your gallbladder are. Your right upper quadrant pain that is going to radiate to your right shoulder, pain triggered by high fat and high volume meals. So the patient may eat something that has a high fat volume and it may cause them some pain and discomfort. Nausea and vomiting, dyspepsia, rebound tenderness, abdominal fullness, inspiratory arrest, fever, clay-colored stools, and dark foamy urine. Continuing with the signs and symptoms, the obstructed bile duct can actually lead to the buildup and excess of bile salts, and these can accumulate in the skin, which is going to lead to the itching or pruritus that's associated with cholelithiasis. Continuing our assessment, we may look for Blumberg sign, and this is going to show us some rebound tenderness. So this is indicative of peritoneal inflammation. We're going to push our fingers deeply and steadily into the abdomen and then quickly release the pressure. Pain that might result may indicate peritoneal inflammation. And then we have inspiratory arrest. This is called Murphy's sign. And this happens when we are palpating the liver border while the patient takes a deep breath. And if they experience pain, it may indicate cholecystitis. If you guys take a look at the picture on the left, you guys can see those little blue gallstones, and they are going to be obstructing common bile and cystic ducts. Labs can be similar to those with peptic ulcer disease, hepatitis, and pancreatitis. So an increased white blood cell count can be inflammation. An increased AST, ALT, or LDH in bilirubin can indicate that there is liver involvement in patients with severe cholecystitis. An increased amylase and lipase can indicate that there is pancreas involvement. For diagnostics, we may do an abdominal x-ray, but this only shows calcified gallstones. A right upper quadrant ultrasound is the best initial test for cholecystitis because edema of the gallbladder is easily visualized. Next, we have a HIDA scan, that's HIDA, and a HIDA scan is going to determine the patency of the biliary system. A lot of times they will give the patient a contrast and insert it into the biliary system, and they will see using an x-ray how well that contrast flows through the biliary system. So a decreased flow can mean that there is a gallbladder disease or there could be obstruction. And then we have an ERCP or an MRCP, and those may be performed if the cause of cholecystitis or cholelithiasis is not known. Non-surgical management, we may make the patient NPO, and we may withhold food and fluids when the patient is having nausea and vomiting, and we would give them antiemetics. We may also give the patient opioids for acute biliary pain, and these drugs may cause the sphincter of Oddi to spasm. We could give them Toradol. This is an NSAID used for mild to moderate pain in these patients. Antibiotics can also be given depending on the cause of the cholecystitis. And gallstone stabilizers or destroyers. The medications for these include ursodiol and chenodiol. These are long-term therapy treatments, and we're going to teach the patient to take them with food and milk. Side effects include diarrhea, vomiting, severe abdominal pain that radiates to their shoulders, and we want to inform the primary care provider if the patient has any of this pain. And the last non-surgical method we have is a percutaneous intrahepatic biliary catheter. This is when a CT or an ultrasound is used to guide the placement of a drain to open blocked ducts, and this can be internal or external. For surgical management, this is a very common procedure, and it's called a cholecystectomy. A lot of times we try to do what we call a lap chole, and that's a laparoscopic cholecystectomy. And this is minimally invasive. The abdomen is inflated with CO2, and the gallbladder is then removed with a laparoscope. The patients may experience discomfort from the CO2 afterwards, and they'll have pain in their chest and shoulders. Early ambulation promotes the absorption of CO2. So for these patients, as soon as they have surgery, they're awake and they're stable. A lot of times we have them get up and walk because that early ambulation is going to help with those pains. If your patient does not have that lap chole, they will have open abdominal surgery. So with the lap chole, they may have about 3 or 4 sites, and they look like little pinholes in the stomach where they put in that scope. But sometimes they may actually have to traditionally cut them open and have open abdominal surgery. This is usually reserved for patients with severe obstructions. The surgeon will remove the gallbladder and explore ducts for potential causes of obstructions, and a JP drain may be inserted. Now for those JP drains, we are going to talk about the care for those just because it is pertinent that you understand how these work. So the drainage in a JP drain is going to be serosanguinous, and it is going to be stained with bile for the first 24 hours, so it might have like a yellowish tinge. For our care, we are going to monitor the drainage amount and color. We are going to secure it to the patient gown so it doesn't get pulled on. And after you empty a JP drain, make sure you press the bulb down and close it back. By pressing that bulb down and capping it, you are creating that negative suction, so suction will work. It has to be pressed down. Usually the surgeon will generally remove the drain in 2 days. But if the patient is still having excess drainage, then they may get sent home with it and have it removed in an outpatient appointment. And I have actually included another YouTube link in the details section of this video just for JP management care. It includes stripping, emptying it, and how you are going to teach the patient to go home with it if they need to. And then for standard post-op care, we are going to manage pain, nausea, vomiting. We are going to encourage early ambulation. The patient will remain NPO until they are fully awake, and we will advance the diet slowly from clear liquids to solids. For nutrition, we are going to encourage a diet high in fiber and low in fat. We want the patient to have small, frequent meals. We are going to monitor weight for weight loss. We are going to monitor BUN, prealbumin, total protein, and transferrin levels to assess nutrition and hydration status. We are also going to monitor for post-cholecystectomy syndrome. This is also called PCS. The causes for this are listed in box 51.2. The signs and symptoms include repeated abdominal and epigastric pain with vomiting and or diarrhea for several weeks or months after surgery. An ERCP will then be performed to determine the cause and to treat this. Moving on to pancreatitis, this is acute pancreatitis. So the pancreas has endocrine and exocrine function. Problems with the endocrine cause diabetes, and exocrine causes issues with the secretion of enzymes that break down starches, proteins, and fats. Acute pancreatitis is caused by serious and sometimes life-threatening inflammation of the pancreas, which is caused by premature activation of excessive pancreatic enzymes. These are normally released in the small intestine. Whenever we have the premature activation of these pancreatic enzymes, these are going to destroy the pancreatic cells through a process called autodigestion. This can range from mild to necrotizing hemorrhagic pancreatitis, which is NHP. This is diffuse bleeding in the pancreatic tissue with fibrosis and tissue death occurring. Many deaths from acute pancreatitis result from irreversible hypovolemic shock due to hemorrhage. Complications include jaundice, diabetes, left lung pleural effusions. It can also cause atelectasis and pneumonia in the elderly. It can cause multi-system organ failure from NHP. It can cause acute respiratory distress, which is ARDS. It can cause pulmonary failure, acute kidney injury, and it can also cause coagulation problems like DIC and shock. So what causes acute pancreatitis? Gallstones and alcohol use account for 70% of acute pancreatitis cases. For our prevention, it's really looking at limiting alcohol because it's going to lower the risk for gallstones. We are looking at a healthy lifestyle, preventing obesity, avoiding high fat and high cholesterol foods, and exercising regularly. This table is going to show you the process of autodigestion in acute pancreatitis. And I understand this kind of looks confusing, so let's just start at the top. You look at your etiologic factors. These are like your risk factors. What is our cause here? So this one thing will go with alcoholism. So alcoholism is going to cause an obstruction. And that obstruction can either go to the left where it just directly is toxic and it injures pancreatic cells, or it can go to the right and instead of just injuring those cells, it can cause the production and release of pancreatic enzymes in an excess amount. So once you go down from that box, you'll see like trypsin, and then on the other side, you'll see where it goes down to elastase, lipase. So these are enzymes that the pancreas can produce in excess due to the obstruction. And below each of these enzymes, it's going to have what is going to happen in the body due to an excess increase of those enzymes. When we do our assessment for acute pancreatitis, patients often report severe and constant abdominal pain. Ask about when the pain occurs, alcohol use, history of alcoholism, pancreatitis, trauma, or biliary tract disease. Ask about recent procedures, recent viral infections, and any medications the patient may be taking. Symptoms may vary depending on the severity of inflammation. Mid-epigastric or left upper quadrant pain can be described as sudden and radiating to the back. Left flank or left shoulder pain can be worsened by laying supine. A gray-blue discoloration of the abdomen and flanks is actually caused by the leaking of pancreatic enzymes into the peritoneal cavity. We are going to monitor vital signs for pancreatic hemorrhage. Think about what you're going to see when your patient is hemorrhaging. How is your body compensating? Oftentimes you're going to see hypotension because we're losing blood volume, and tachycardia because your heart is trying to compensate. For our labs, take a look at table 51.1. Elevated pancreatic enzymes such as amylase, lipase, and trypsin, and think about why each is elevated, and it is listed in that table. For our imaging, usually we do a contrast CT as our most reliable imaging assessment. Interventions are aimed at controlling pain, decreasing GI tract activity, which decrease pancreatic activity. A lot of times we're going to do an NG tube for drainage and suction, and it's going to be used for severely ill patients with continuous vomiting and biliary obstruction. Whenever we put that NG tube to suction, a lot of times we're going to do low intermittent suction, and it's going to give the bowels some rest, and it's going to take all that excess off of the stomach and relieve any kind of pressure that we might have on your pancreas, and it's going to decrease that pancreatic activity. Drugs like Pepcid and Protonix, generic name for Protonix is pantoprazole, those are going to be prescribed to decrease stomach acid secretion. And antibiotics are needed for those with necrotizing pancreatitis or an abscess. If pancreatitis was caused by gallstones, an ERCP with a sphincterectomy is performed to remove them. For surgical intervention, if this ERCP is unsuccessful, a lap chole can be performed to remove any type of gallstones that can be causing pancreatitis. And pancreatic cysts or abscesses can also be drained while they are doing a lap chole. And then for nutrition, our patient is going to be NPO until tolerated. A lot of times our patients who have pancreatitis are going to have IV fluids and be NPO to help control that nausea and vomiting. We're also going to use antiemetics to control nausea and vomiting. Patients may be started on tube feedings, which is preferred over TPN due to less complications. Whenever you are trying to collaborate and decide what nutrition your patient is going to need, you are going to work with the primary care provider, the registered dietitian nutritionist, and the pharmacist. When food is tolerated, recommend small frequent meals, moderate to high carbs, low fat, and high protein meals. We want to avoid GI stimulants such as caffeine and alcohol. So we talked about acute pancreatitis. Let's flip the coin and talk about chronic pancreatitis. Chronic pancreatitis is the progressive destructive pancreatitis, and that is going to have remissions and exacerbations. Exacerbations are also known as flare-ups. That's a good token to put in your vocabulary because you will see it with multiple diseases. Chronic pancreatitis leads to poor pancreatic function. So we do have chronic calcifying pancreatitis, CCP. This is the most common type, and chronic pancreatitis in this situation is caused by alcoholism. We also have chronic obstructive pancreatitis. This is caused by inflammation, sphincter of Oddi obstruction, and often gallstones. We have autoimmune pancreatitis. This is chronic inflammation caused by the invasion of immunoglobulins in the pancreas, and it can be linked to other organ cancers. And then finally, we have idiopathic and hereditary pancreatitis. This is associated with gene mutations, and these patients are at a higher risk for pancreatic cancer. So whenever we do our assessment for chronic pancreatitis, you guys can take a look at box 50.1 for your recognizing cues and signs and symptoms. They're also listed here. But the decreased pancreatic enzyme secretion causes malabsorption of fats, which is the cause of steatorrhea. This is oily and smelly stools. Non-surgical options. Opioids are initially used, but they can cause dependency. Surgical interventions are indicated for incapacitating pain relapses, pancreatic abscess, or pancreatic pseudocysts. For a pancreatic enzyme replacement, oral capsules containing amylase, lipase, and protease are going to be used to break down food and prevent malnutrition. So you may give your patient their lunch tray and they may tell you, hey, I need to take my Creon because that is their pancreatic enzyme replacement. They're going to take it with their food. So for patient teaching, we do not crush or chew these medications if they are delayed or extended release. A lot of them are that come in the capsules. We take these with meals and snacks. You do not wait to give this after the patient has eaten. We are going to record stool consistency and how many the patient has each day. Effective therapy is evident by less frequent and fatty stools, and the dosage may change depending on the severity of malabsorption. For prevention, we want to avoid triggers such as caffeine. We want to avoid alcohol, avoid nicotine. They're going to have a bland, low-fat, high-protein, and moderate-carb diet. Remember, we are promoting small, frequent meals and high-calorie snacks. We want the patient to take enzymes as prescribed, and they need to balance their rest with their activity. Moving forward, let's talk about pancreatic cancer. So pancreatic cancer is a leading cause of cancer deaths in the U.S. If you don't know somebody who has had pancreatic cancer, someone you know does know someone who's had pancreatic cancer. It's more common than we would like it to be, and it can be very, very aggressive, simply because early diagnosis is difficult and it's often discovered in late stages, and it has low survival rates because of this. It may result from a primary tumor or metastasis from other cancers. A venous thromboembolism is a major complication. Necrotic products of the pancreatic tumor may have thromboplastic properties, causing a hypercoagulable state of the blood. This is also related to decreased motility and multiple surgeries. The cause is unknown, but there are several risk factors for pancreatic cancer, including smoking and tobacco use, obesity, chronic pancreatitis, cirrhosis, being older than 65, and genetic syndromes. So for recognizing cues, our assessment, box 51.7 does have these. One of the things I want to point out is the first sign may actually be jaundice, but even then, it's a late sign of the disease. Once again, this cancer is so hard to detect in the early stages, and a lot of the times we don't even know about it. We don't diagnose until the patient is already in the advanced stages of the disease. For our interventions here, chemotherapy has low rates of success in increasing survival time, but it may help with combined therapies. We often use morphine for pain control, and patients may have intensive beam radiation for resectable pancreatic cancer or for pain relief in advanced cancer by shrinking cells and alleviating obstructions. For surgery, we have the partial pancreatectomy for those with small tumors. One of these surgeries is called a Whipple procedure. The actual name for this is a pancreaticoduodenectomy, but that is a mouthful, so we call it the Whipple procedure. And this treats tumors in the head and neck of the pancreas. This is the removal of the proximal head of the pancreas, duodenum, part of the jejunum, part and all of the stomach and gallbladder with anastomosis, which is the connection of the pancreatic duct, common bile duct, and the stomach to the jejunum to restore digestion. You don't have to know every single part of that. That is just an explanation of the procedure. I know it seems like it's a lot, but that's the Whipple procedure. And you do need to know that we use the Whipple procedure as a surgery for pancreatic cancer with small tumors. For post-op care, your patient is going to be NPO, and they will have an NG tube to low intermittent suction. We are going to place these patients in a semi-Fowler's position. We are going to give them IV hydration, and we are going to assess for complications. These complications are listed on table 51.2, and the signs and symptoms include shortness of breath, elevated temperature, chest pain, tachycardia, low blood pressure, decreased bowel sounds, or no flatulence or BMs. Go ahead to read your scenario here. Read your question and review your answer choices, and we will answer the question together on the next slide. The answer here is B as in boy. A serum amylase of 200 is elevated. The normal range is approximately 23 to 85. This is why it's important to understand your lab values. We can see that the lipase is in a normal range, the white blood cell count is in a normal range, and glucose is in a normal range. Go ahead and take a moment to read the question regarding the previous situation. Make sure you select all that apply. You can go ahead and pause your video here while you answer the question, and I will see you on the next slide for an answer. So what did you get? The answers here are B as in boy, C as in Charlie, D as in Delta, and E as in Echo. All of these diseases, with the exception of strep throat, are potential complications of acute pancreatitis. Go ahead and take a moment to read your question as based on the scenario. Choose your answer choice, and you can pause your video here, and we will discuss the answer on the next slide. The answer to this question is D as in Delta. The best option out of these choices is going to be morphine sulfate using a PCA. Go ahead and read your question and review your answer choices. You can pause your video here, and we will discuss the answers on the next slide. The answer to this question is A as in alpha. We want those small, frequent meals. Clients may experience nausea and vomiting, but it shouldn't be expected. High carbohydrate, high protein, and low fat foods should be included in the diet. Alcohol and caffeine should be avoided. We do not want to have these in moderate amounts. So your client is being discharged. Think about what teaching the nurse is going to provide regarding when the client should notify the healthcare provider. The client should be instructed to notify the healthcare provider if acute abdominal pain occurs. Also, jaundice, clay-colored stools, or dark urine should be reported because these are signs of biliary tract disease that may indicate complications as the disease progresses. There are 51 audience response system questions. So these are going to be a couple of multiple choice questions. You can use your book for this if you'd like to. I do recommend trying to answer these without using your book to really test your knowledge to see if there are areas that you need to go over with in your studying. To review your question here, look at your answer choices and choose the best one. For this client, they are going to have chronic cholecystitis and they are reporting pruritus, clay-colored stools, and they are avoiding dark, frothy urine. Think about what you think might be going on and what labs you're going to see in a client who has these things going on. B as in boy. Excess circulating bilirubin is present with chronic cholecystitis, and it is responsible for pruritus and changes in stool and urine color. Cholecystitis is associated with several risks, including hepatic disease, pancreatitis, and peritonitis. So monitoring liver function, pancreatic laboratory results, and white blood cell counts are also very important. However, for this question, our priority lab is going to be our bilirubin. So go ahead and take a look at your question here and review your answer results. Once again, this is one of our priority questions. To look over your answer choices, you can pause your video here, and we will review the answer on the next slide. The answer to this question is D as in Delta. So the client with pancreatitis may develop pulmonary complications, pleural effusions, pulmonary infiltrates, and acute respiratory failure, also known as ARDS. Increases in respiratory effort is an important assessment variable in the care of a client with pancreatitis. Clients may also be hyperglycemic and hypovolemic, and assessing and treating endocrine function of the pancreas and perfusion variables are also very important. Once again, with this being an ABC question, it's always about that priority. We're going to look at our airway first and just think about pancreatitis and all of the side effects it can have. End of chapter 51. Good job, you got all the way through it. If you have any questions or you're not sure about a certain concept, please don't hesitate to reach out to your instructor. It is what we're here for, and we don't mind helping you. Thank you for listening to my presentation, and good luck on your exam.